I think I'm going to skip some of the slides towards the end because of the time constraint. So over here, Site Asia, we tend to limit our presentation short, but more on the discussion part, right? Okay, so the overview of my presentation is patient assessment. I think is still one of the most important part of before injections, and it should be individualized according to every patient. A bit on the injection technique. I'm not going to talk about the basic injection technique because I think most of us here are well versed with the basic things. So I'm going to focus just a bit about the mesenteric hypertrophy, the infraorbital lines, the bunny lines. I'm going to talk about botulinum toxin in men and a bit on the clinical efficacy with different types of toxin and some myths to debunk. So patient assessment should be individualized because beauty is in the eyes of the beholder.
So can you see it?
Sure.
Yeah, sure. Yeah, so my talk is a bit different, but also kind of similar to the talk of Peter. And the adverse events, I categorize them in injection or toxin related. Yeah. And when it's to injection related, there are two major adverse events. One is pain, and the other one is hematoma. And I'm specifically interested in the pain issue because how do you differentiate yourself from a colleague who uses the same toxin? And I was told by my patients that I'm injecting for them less painful. And what might be the reasons for that? It might be because I'm so cool and patients are really relaxed and make this kind of immediate hypnosis. But the two things I always do is I use preserved saline. Yeah.
Interestingly enough, there is a recent publication from February 2022, which mentioned a new technique for treating glabellar complex using a 3-point injection technique, which targets exclusively the bony origin of the procerus and the corrugator supercilii without injecting the lateral part of it. But you know, being old has some advantages, so it is basically not a new technique. The first publication on using 3 injection points pattern has been published already in 2006 by Berthold RZANY, Benjamin Asher, and other authors. And they basically did not find any significant difference in efficacy of treating glabellar complex using 3 injection sites versus 5 injection sites.
Because this is where I see most of the atrophies, these are the common things, and the silicone thing I'm not so able to understand, because with a silicone oil, why should you get an atrophy if you have silicone in the skin? Usually get hypertrophy and you get granuloma or something like this. I'm not able to understand it. So
yeah, you're right.
I've never seen it in my patients. I would just watch it, and I can't remember how long it lasted, if it came back normally or if they did some filler injections to have it reduced. Yeah.
I have not really similar, but very interesting experience, because when we paralyze the frontalis muscle, which is not very, sometimes very thin, sometimes a little bit thick, but when you paralyze them, the thickness of the muscle will be thinner. So once the patient have some depressed change before injection, actually will be masked by the active muscle activity in every day. But when we do the paralyzed medicine to relax them, so we can see the depression normally right after when the muscle was relaxed. So probably that's the reason. And because one of my patients, they have very high nasal bridge at the beginning, but when I do the glabellus the glabellus area injection, right after that, his nose became flat a few days later, and the high nose become low nose. So the one the height of the nasal bridge came back a few months later. So I think that's probably part of the reason that actually our facial contour was usually are tainted by the muscle activity. So when we paralyze some of them, so we'll see the real me, the real patient. Yeah.
Yeah,
so,
but the funny thing is they mentioned the morphia, like, right?
Yes,
so that means, yeah, that means there's some hardening of the skin, you know. Normally after Botox, we don't get the surface, the dermis hardening, intradermal hardening. So that's funny thing. I suppose they didn't biopsy it to look at it.
Yeah, it's hard to do biopsy for them.
Yeah, for aesthetic purpose.